Hi, welcome back to Brain Pods. With me is Dr. Asadi. He gave your sleep and he gave your seizure talk during HHD5. We are expanding that now and are going to include some management. Thank you very much for joining me.
Pleasure to be here.
All right. Well, without further ado, let's go ahead and get right into it.
All right. So here's just very quickly the goals for what we're trying to do here today. Classify a couple of different seizure types and epilepsies, differentiate some acute symptomatic seizure types and epilepsy syndromes based on their clinical characteristics, identify a few common seizure mimics, this is really important especially in the hospital, and describe the overall diagnostic approach to a first-time seizure and when medication is required. Sort of more of the same, here's the outline.
All right, let's go ahead and get started with a video. This is a patient you might see when you are in the hospital as your first-year resident.
Hey, pretty smart. Tissue paper. Here at the wedding. Here at the cry. Handkerchief. No.
Oh, look, isn't this adorable? Ross let Nana dress mine.
Hello. Hey.
Hey, did you get your invitation to Ross's wedding?
No.
Next on the
Oh, and I get to bring a guest who showed him.
Jealous, no, I
So we saw the tonic phase. Now it's starting to move into a clonic phase.
So did but you should see your faces. Hey, hey. See, maybe that's what we actually get.
Hey, will somebody come in here?
And it's pretty much over at that point. You know, part of medical school is just to be able to see everything at least one time. And so we're going to show you a lot of videos today, hopefully to give you just a little bit of a perspective of what these clinical phenomena look like.
All right, so sort of introduce a few things here. Let me see if I can't get you to care about seizures. So first and foremost, seizure history I think is interesting and actually quite weird. These are people who, if you go back in time, and really not that far back in time, people thought these people were possessed. They were, had demons living within them.
Ended up in institutions.
Yeah, sometimes outright hunted. This was not something people that really ever understood very well. The other thing is that seizures are really quite scary to pretty much everybody. It's an acute thing. The person is shaking about uncontrollably. Pretty much everybody freaks out in those situations.
Yeah, your job is to not, as the doctor, is to be the one person who's not freaking out.
All right. Otherwise, the symptomatology of seizures and epilepsy is really quite varied, and I would say quite interesting. And as always, this is on your test.
Step 2 in particular, there will be a step 2 question from this hour.
All right. This next slide is really just sort of a reference slide that has some definitions for you. The thing I want to point out is ictus or ictal. Whenever we're talking about this, we're talking about any sudden attack. And so from that, you'll hear us talk about an interictal or a postictal period. We're dealing there with the period between seizures or following a seizure. The other thing is spell. So this is just an important thing to note. Any sort of transient shaking or loss of consciousness, it's not automatically a seizure, and we will call this, especially in neurology, a spell until we've sort of delineated what actually happened, or at least our best guess.
And you can go ahead and read the definitions for seizure and epilepsy there. We are going to be coming back to that again a little later.
All right, so just sort of taking the two words I'm using here and sort of making it explicit, because they are sometimes used interchangeably, which is incorrect. So the seizure is really the event itself, whether it's a shaking seizure or not. That's the event. Epilepsy is the disease process that involves recurring, unprovoked seizures, and I would underline unprovoked. A little bit about epidemiology. So seizures are not uncommon.
Yep.
Right? This is about 80 per 100,000 incidents per year in North America. It makes a lifetime prevalence of about 9%. So of those of you listening to this right now, that's 1 in 10 of you are going to have a seizure in your lifetime. Epilepsy, it's sort of half of everything I just said. So incidence is about 45 out of 100,000, lifetime prevalence of 4%, and the overall prevalence is 1%. So it's as common as like schizophrenia, for example. That equals about 3 million cases in the U.S. and 65 million over the course or over the world. One thing to note, as we're sort of pointing out with the pointer there, is that epilepsy, or at least incidence of epilepsy and onset of seizures, is what we would call bimodal. So you'll see the incidence is highest when we're really young, because you see a lot more genetic syndromes and things like that there, and then it starts to really increase as we get older, and a lot of that is due to sort of acquired risk factors, so things like strokes and tumors and things we'll all get into.
And we have more focal epilepsy when we're older and more general epilepsy when we're younger.
All right, so probably define what a seizure is, right?
Yep.
In the seizure talk. So there's 3 key features we think about. First off is that the neurons, they increase, each individual neuron increases its firing rate dramatically. So it's not doing its sort of normal everyday thing, it's really increased in its overall rate. If you take a group of neurons or a neuronal pool, you'll see abnormal synchrony. So the key word there is abnormal.
Yep.
There are periods of normal synchrony that Dr. Howell could mention.
Such
in a
as
second.
slow wave sleep, for example.
So that would be something that normally happens, but this is definitely abnormal. And then if you put these people on an EEG, which is sort of electrodes on the scalp to measure brainwave activity, you'll see a rhythmic, repetitive, or oscillatory pattern. So what about sort of the definition of epilepsy? So this is sort of, the gatekeepers for this is the International League Against Epilepsy. That's what we mean up there by ILAE. The essential thing to remember is that epilepsy is an enduring predisposition to have spontaneous seizures. In the sort of everyday world that we all live in, that sort of boils down to one of a couple of things. Either you can have at least 2 unprovoked, again, underline unprovoked, seizures that occur greater than 24 hours apart.
Yep.
You can have this next bullet point, which is a mouthful, sort of unprovoked seizure and a probability of further seizures similar to the general occurrence risk of at least 60% after 2 unprovoked seizures occurring over the next 10 years. I really defer in most cases to the epileptologist.
We'll leave it to the epileptologist for that one.
And the next and then sort of final thing here is sort of if you diagnose somebody with an epilepsy syndrome, you've diagnosed them with epilepsy, correct?
Such as absence epilepsy, juvenile myoclonic epilepsy, other examples we'll get to later.
Exactly. The other thing, and I will hammer this home multiple times throughout this lecture, but seizures that occur due to a provocation, such as alcohol withdrawal, low glucose, if they keep happening, but it's clearly predicated on that provocation, that is not epilepsy.
So the alcoholic who keeps hitting your doorstep, hitting your emergency department at Monday, Tuesday night because of binge drinking on the weekends does not have epilepsy.
All right. How about how the seizure actually happens and therefore who can have one? So here we think of a threshold concept, just like you've already learned about when we talk about the action potential of a neuron or a heart muscle cell. So you have a baseline brain activity, right? Because you're going about your day, you're taking in all kinds of information from what you see to what you hear to what you're thinking, and that all sort of equals different neurons firing and a sort of overall brain activity. There is a point, and here I would sort of highlight with the blue line, past which if you go above that, you've sort of reached a threshold to have a seizure. It's too much activity, right? So there's normal and then there's abnormal, and when you go past that abnormal, just like the threshold for an action potential, because this is like, say, millions of action potentials all at once,
Yep.
all of a sudden you have a seizure. The difference between, say, your everyday average person who doesn't have seizures or epilepsy and one who does is that their threshold is lower, which means it takes relatively less
Yep.
brain activity, or a relatively less increase in their brain activity to hit this threshold and have a seizure. The next thing is, let's say you have epilepsy and you add in some sort of stressor. It could be sleep deprivation. In this sort of comical picture here, it's cocaine, or basically it's all drugs that they're mentioning here. You do that, you lower your threshold in the acute setting even lower, and sometimes even then your normal brain activity can push you into a seizure.
Okay.
The point there, anybody can seize under the right circumstances.
Anybody. And when we treat epilepsy, what we're doing is we're overall decreasing the brain activity to get it farther away from what those thresholds are.
All right. So let's talk a little bit more about those stressors. So what sort of pushes a person past that threshold? So that first bullet point, that's really the I would say that encompasses literally everything else in this slide. So it's a stress, or a stressor as we would say. Anything that increases stress can do it. The big ones, medications, bupropion is a very common one. Otherwise, drug use, cocaine, amphetamines, even excess caffeine, right, in the right setting can do it. Sleep deprivation is a big one. Traumas, various illnesses, especially of the if it's an illness sort of inherent to the brain or supportive structures, can do it. Hypoglycemia can do it. You drop your blood sugar low enough, you can definitely have a seizure. Metabolic or electrolyte abnormalities. The big one here is hyponatremia, so low blood sodium. Otherwise, hypocalcemia, hypomagnesemia, hypo or hyperglycemia, just sort of mention that again, or uremia in certain patients can all do it. One thing I want to point out, this is the same list whether or not you are epileptic, or whether or not you have epilepsy or you don't, right? So again, the patient who doesn't have epilepsy but sort of has way too much of one of these, they can seize.
Yep.
The other thing is all of these are essentially reversible. So if you find one of these as sort of your cause,
Yep.
you seek to reverse it through one form or another. And again, to hammer this point home, let's say if you continue to have seizures because you keep hitting one of these, your alcohol, your whatever,
Yep.
it's not epilepsy.
In terms of what I would think of as the three most clinically relevant items on this list are, one, medications, particular medications that have a adrenergic component to them, such as these activating antidepressants such as bupropion and venlafaxine. I think about low sodium, and I think about alcohol withdrawal.
All right, so why care, right? So why are seizures bad? So first off, sort of referencing what I said at the beginning, we've evolved from banishing or doing all kinds of crazy things, for the most part,
Right.
to these people, but we haven't evolved that much. And unfortunately, people who have seizures are really, especially like poorly controlled epilepsy, they have lots of issues typically with their overall self-image, their social image. There is a clearly defined association with depression.
Yep.
The medications that we use, anti-epileptics as a whole, these are not all benign drugs. They have side effects. Those side effects can be very limiting. Next, driving restrictions. So a person who has a seizure, or really any loss of consciousness for any reason, in the state of Minnesota, they can't drive for 3 months. And it varies state to state, but you can think about that, any person who drives on a daily basis, but what if, they're a truck driver, they essentially live by their ability to
Yep.
drive?
Yep.
That is, that can be extremely damaging to their sense of self-worth, their ability to make money, their ability to live, really. If you have poorly controlled seizures in general, even if you're not driving all the time, you can still have employment difficulties, right? Because
Yep.
it's hard to get through the day if you're seizing all the time. And then the next couple of bullet points basically underscore that the seizure itself, especially if it's what we call a generalized tonic-clonic or sort of related seizure, which we'll get to, that moment in time is dangerous, right? If you fall or you're having a seizure, you're not really able to protect yourself, so injury is definitely possible. It's also an extremely high energy state. You have lots of increased need for glucose and oxygen, right? Because all these neurons are firing, right? So they're going to use up their available glucose, their oxygen. You're going to need more.
Mm-hmm.
The patient isn't technically breathing during a generalized seizure, and all of that can essentially end in brain damage,
Right.
especially with people who have a long-term uncontrolled seizures.
Seizures are epileptogenic. So if you have enough seizures, you are setting up your brain to have more seizures. So that in and of itself is a reason to control these aggressively.
All right. So, how do we classify seizures? Now, there's a couple of systems, and it's currently undergoing change. It actually, very recently, there was a change in terminology. We are going to use the old terminology because it's still pretty universally known, and I won't really reference the new one, but just note that sort of as you go through this year and next year, you might see the new terminology
Sure.
sort of gain more acceptance. So the first way is sort of by mode of onset, and this is largely essentially clinical, or it's based clinically, and it's overall by your level of consciousness, sort of assessment thereof. The two types are focal partial, which essentially equal a discrete part of the brain. We'll talk about that a little bit more. Or generalized, which essentially means that the whole cortex is involved. The other way to do it is based on the etiology of the seizure, so if it's a genetic syndrome, or there's a structural change somewhere in the brain, sort of some structural abnormality, whether it's congenital or acquired does not matter in that case. And then what we call sort of distinct electroclinical syndromes, and this is the epileptologists looking on EEGs and sort of picking out clear patterns, or at least what them are clear patterns that underlie a distinct type of seizure, or etiology of seizure. Here's the basic overlap that I think helps simplify things a little bit. Genetic etiology basically equals generalized onset. It's G equals G, that's how I remember it, and I think you put that in your brain and you will remember it forever. Structural etiology essentially equals focal or partial onset, and we'll actually get into why in the next couple of slides. So, let's start with focal partial, the sort of most simple ones. So this, basically by definition, denotes that there is some sort of structural abnormality, the so-called lesion, somewhere in the brain. And the fact that this lesion is there, right, it's not the norm, and ergo, it can essentially act as the seizure starter, the epileptogenic focus, where the seizures sort of come out of, because it could be irritating, or for whatever reason the brain doesn't like it there, it's a little irritable, the person can seize. Two types, simple partial, complex partial. Very sort of easy to remember distinction between the two of them. Simple partial, you have preserved alertness and preserved awareness, whereas in complex partial, you have preserved alertness and impaired awareness. I'm sure somebody is thinking to themselves, what are you talking about? So, I'll say this, alertness in the way that I sort of simplify it is, I mean, that person is awake, so you haven't lost any consciousness. And when you think about awareness, the sort of differentiating factor, that's sort of this person's ability to interact with their environment. Whether or not they can speak is sort of irrelevant, but they are either sort of able to take in information and in some way, shape, or form respond, or they're not.
Yep.
When it comes to focal partial, there's usually no true post-ictal, and something to note that the simple partial can actually be an aura for a complex seizure. So over here, we're kind of highlighting, let's just define those things so that we're all on the same page. The aura is a perceptual disturbance that will reflect the initial seizure discharge. It is, in effect, a small seizure.
Mm-hmm.
It can be sensory, it can be experiential, it can be any sort of small thing that feels off to the patient.
And this can be related, in when you conceptualize this is related to the auras of migraines, which are just the initial discharge from that abnormal neuronal activity.
The other thing is the post-ictal period. This is a very typically stereotyped period right after a seizure, where a person could be drowsy, confused, they might even go to sleep, they might have some nausea, some vomiting, even some headache. It can last seconds to hours. The point here is that you do not see this in a focal partial seizure.
Got it.
Couple of types that we want to go through, and the sort of simple thing here is we look at this kind of based on what lobe of the brain it's coming from, and essentially what's happening or what's sort of controlled by that lobe is what you're probably going to get with the seizure.
Mm-hmm. So
the most common overall is the temporal lobe ones. Here you can get a sort of preictal aura. You might get a sensation of deja vu, very common. Epigastric sensation, or one of just sort of nausea, fear, or even olfactory hallucinations. My very first seizure patient, my first year of residency, smelled evil.
Oh.
She was a former priest, and her aura was the smelling of evil before she'd have her little focal partial seizure.
Wow.
I never quite was sure what that was. I think maybe sulfur, maybe, but So you can see how that sort of reflects sort of localization of where the seizure is starting. Next most common is frontal lobe. So here you might see things that are in the frontal lobe. So you have your frontal eye fields up there, so you might see forced deviation away from the seizure. Compare that, by the way, to what we saw or we'll see in the stroke lecture,
Right.
where you're sort of looking towards the lesion. Here you're looking away.
Right. So the frontal eye field, so your right frontal eye field moves your eyes to the left. So if you have a seizure where you're activating that, that's going to move it over to the left. If you've had a stroke there, you're going to have going to be the contralateral side, which is going to be driving the eyes over towards your side where the stroke occurred.
Also in the frontal lobe, especially on the left side, right, we have our speech areas. So if it's in the right place, you might have a speech disturbance or just outright speech arrest.
Speech or language. I think we're using those terms interchangeably here.
Yes. The other thing is certain motor activities. So there's like a Jacksonian march. This is jerking of a distal limb with ipsilateral face involvement, or we call a fencer's or figure 4 posture. In the parietal lobe, you'll get like paresthesia, sensory disturbances. And in the occipital lobe, so where your visual cortices are, you can get what we call positive visual phenomena. So things that aren't there, flashes, colors, something like that.
So here is a simple focal seizure. Involves motor activity of his left side. He is awake, he's alert, and he's aware. And we'll just go ahead and play that right now.
It's okay. Go get my phone, please.
It's okay, Shell.
He's coming out.
It's okay.
You good?
Yeah, he's relaxing slowly. I can tell.
Want me to call 911 or not?
No.
He's done. I didn't know where yours was. I got a call.
Here, I got mine to stay on. Here.
Can you talk normal?
Huh?
She just wants you to talk to see if you can talk
I
normal.
think I can.
Yeah, he's pretty good.
So he's back. On to complex partial seizures.
All right, so here again you have the presence of a change in the level of consciousness, so your awareness is different, but you have preserved alertness. Again, there's usually going to be no true post-ictal period. One sort of key differentiating feature, though, is that a person should not remember this. So there's amnesia for the actual event. One other thing, automatisms. So this is somewhat, it can happen in complex partials, and it's essentially a repetitive complex motor activity. So it could be fidgeting, it could be chewing motions, it could be things like that. The patient is not in control. It's part and parcel of the seizure semiology.
Could be picking at clothes, which we'll see an example of that in just a couple minutes.
All right, so again, automatisms. One other thing to mention is that if you see that is strongly localizing to the temporal lobe. If you're getting the sense lots of seizures are occurring in the temporal lobes.
Yep.
You might also see staring spells with complex partials. This is easy to confuse with absence seizures. We will differentiate that a little bit more later, but essentially this is going to be your adolescent or your adult. Absence is a childhood thing. So with that you might have behavioral or arrest of language. And again, localization. So temporal lobe is the most common. Frontal lobes can happen less so with the parietal and the occipital.
This is a reenactment from the United Kingdom National Health Service, but it is a wonderful reenactment of a complex partial seizure. You'll see sudden speech arrest. You'll see automatisms, picking at clothing. He's still able to maintain posture, lasts for a few minutes, and a pretty quick recovery after the event happens.
Have you doing anything to your homework yet?
I'm telling you, it's well hard. Started doing it last night, and then I started texting Edda, and I can't believe that. He's gonna be late yet again. Haley, what you looking at? Miss!
Girls, you should be in lessons.
Mrs. Taylor!
Justine, I need you to calm down. Hayley? Hey, it's Miss Baxter. Just to get you to sit down for a minute, let's pop into Miss Renshaw's class. That's it. Justine's going to come too, aren't you, love? That's it, love. Just pop in here and have a sit down for a minute.
Should we be alright now?
Yeah, don't worry, Justine. You alright, Hayley? Just have one of your seizures. No, are you going to be alright, or do you want me to call your mum?
I'll be alright.
Okay. Well, you take a couple of minutes here, and then we'll go on through to class.
A wonderful example of a complex partial seizure.
All right. So, a couple of key features of focal partial, and then sort of going into the complex partial. So, simple partials can evolve to complex partials, so they don't have to stay simple partial. As the seizure goes on, it can evolve into something else. And not just complex partial. A simple or a complex partial seizure can actually become what we call a generalized seizure, where you have complete loss of consciousness. The seizure itself, or seizures themselves, are inherently cortical, so they don't start from the axonal white matter tracts. And this is something you'll see us kind of deal with, I would say, in the hospital a lot. If you get it, people end up with MRIs, you see something in the white matter. Is that causing the seizure? The answer really is no. That shouldn't be what's doing it. The issue is with the neuronal gray matter populations. The other thing is that seizures need to be generalized to cause a loss of consciousness or a change in your level of consciousness. Moving on to generalized. Again, here there's a true loss of consciousness, and there are two main types. So there's primary generalized, and here's where you lose consciousness from the start. Two subtypes of that: convulsive. Here is your generalized tonic-clonic seizure, or GTC, or you might have heard the term grand mal at some point in your life. And then there's sort of a non-convulsive, where you don't get the whole body sort of stereotypical shaking, but you do have the loss of conscious. Within that subtype, there's two more subtypes, one of which is absence, we'll talk about, otherwise known as the petit mal, and myoclonic. And then there's secondary generalized, which we sort of talked about before. So this is, seizure starts as a simple partial, complex partial, and then ends up generalized. All right, so going through the sort of semiology of a generalized seizure, so there's sort of three phases that can be there. And we'll have an example coming up where it's not exactly in the order that we're going to go in, but this is the outline. So you'd have your potential for a preictal phase. This is your aura, which many people have, but not everybody. Again, if you have that, it's sort of a focal onset. Then you'd have your ictal phase, so this is the actual, the big part of the seizure. Typically, you're going to see a tonic period, then a clonic period, which we saw in the first video of a seizure. But just to sort of reiterate and explain a little further, the tonic phase is this tensing of muscles, sort of over the entirety of your body. So it gives you this abnormal posturing. You essentially get extension of limbs. I've learned it essentially because your extensors can be a little bit stronger than your flexors in a lot of cases, so it seems that they win out.
Interesting.
Your eyes might roll back, and sometimes you'll get an ictal cry. And this is essentially because your diaphragm is contracted, and it's pushing against your also contracted and closed glottis. So you're pushing air out, and you can get a little very, very stereotypical...
loud, frightening kind of cry, scream.
Yes.
Yeah.
Next part of that is your clonic phase. This is the convulsive phase. This is what everybody, I think, knows about. You might have seen it in real life, or otherwise probably seen it in a movie somewhere. So the person is shaking in a rhythmic and somewhat synchronous fashion. Throughout this period, you might see cyanosis, because again, these people aren't breathing during this time. The patient can also bite their tongue. You might also see urinary or even bowel incontinence, because it's just part of the semiology. Then you'd leave, the next part is the postictal. So this can be a significant issue, especially in prolonged generalized tonic-clonic seizures. So it is this stereotyped confusion, maybe nausea, vomiting, as we mentioned. Person will initially pretty much be limp and basically unresponsive. Then they could be sleepy. They might even pass out and go to sleep for a while. So here's just a review slide to go over some of the more key parts of focal and generalized seizures.
Okay, so here's a video. This is a secondary generalized seizure. By the time this video gets started, the patient has already hit the event button because he realized that he was having an aura. So that's the beginning of the event. You soon will see him start to develop kind of focal clonic movements that spread over the course over his body. Later on, he does have a little bit of posturing. Don't know if I would necessarily even call that a tonic phase just yet. But then there is a period of confusion and atonia and relaxation.
Okay, there you go. I'm going to get some Advent out this. Well, yeah, but he was only 90 seconds last time. The doctor's here. 90 seconds is longer than that. According to the thing, it was only 90 seconds. What you were seeing was post-pistol. And I'm going to get over here to the shoulder. Billy, we're trying to get I'll get him on his side, bite his tongue. I'm not going to do it. What? You don't use that anymore, do you? I don't know. I thought maybe get him on his side here. Two milligrams now. I'm going to keep his shoulder stabilized here. I'm going to keep it stabilized. Yes, he is. Diane, get another drink. I need some oxygen. Get another drink from here besides Diane. I know Diane's getting me out of bed. She's just doing a little action on me. Post it. Okay.
All of that took less than 2 minutes. If you're in the room, it feels like it goes on for a long time. If you're a family member, it feels like it's forever. But a classic example of a secondary generalized seizure.
All right, this next slide I put in really just to sort of give you an idea or sort of drive home the point of sort of what's happening during a seizure. So it's a cartoon representation of an EEG and sort of what's happening between partial and generalized seizures. So again, the EEG, you can kind of think of it as a really complex EKG where the leads there are many leads, many more than on an EKG, and they're all over they're in these lines sort of all over your scalp. And here you have this would be different leads that's just capturing your normal brain activity, right? We mentioned at the beginning, as you're going about your day, you're thinking, doing stuff, information's coming in, and so this is normal. If you have a partial seizure, so you see part of the brain is getting really sort of hyped up here. Generalized, essentially the whole brain is going, and that's just to basically give you a little oversimplification. You don't have to know much else about EEGs as far as this lecture is concerned. All right, so let's get a little bit into the sort of seizure types just by etiology, the other way of classifying, as we mentioned. So looking at genetic types, so the first one would be childhood absence seizures, otherwise known as petit mal. I would take this whole slide and just commit it to memory, because this is essentially, and I mean I can say this having gone through the shelf, step 1, 2, 3, it's the same information, and it'll be on every test forever. I answered a question on absence literally every time. So this is a childhood disorder. Again, it's really not, shouldn't be coming on past the age of about 8 or so. It's elementary school children. It's characterized by a very brief behavioral or speech/language arrest. It should last less than 15 seconds, right? It should not go on and on and on. The patient, again, it's generalized. They do not remember the event, but they come out of it real quickly, so there should be no true post-ictal for these patients. It's sort of like a staring spell, so there is no loss of body tone. These people don't just collapse on you. They kind of just stop for a little while. You can provoke it, especially like if you're in the office with these patients, by hyperventilation. It is not uncommon. It's 8 per 100,000. So you will come across this almost certainly while you're on rotation. EEG is very sort of stereotyped. It's what we call a generalized, and again, underline generalized. 3 hertz spike and wave, that's a buzzword. Again, I just put that in your memory bank and remember it forever. Treatment is also super easy to remember. It's ethosuximide. And I don't know of anything else that we use that drug for. It's the answer for absence seizures and really nothing else. Prognosis, you're going to be asked about prognosis, right? These are young children, so their parents, when they sort of catch wind of this patient, my kid might be having seizures, they're going to be understandably sort of confused, afraid, anxious, whatever. They're going to ask you about prognosis. Good news there is this is typically very benign and likely will remit by the time that the child hits adolescence. If it doesn't, you likely are going to progress to JME, juvenile myoclonic epilepsy. We will talk about that in a few slides. But most of these kids are going to have remission. The other thing is to just sort of remind you, if you see the same clinical picture, if something looks like absence seizures, but that patient is an adolescent or an adult, you're almost certainly dealing with a complex partial. Adolescence is childhood.
Right. So the young lady we saw in the video before with this more prolonged staring spells, that is a complex partial seizure as opposed to an absence, which is a generalized seizure. So here is an example of a young guy who's got absence epilepsy. It can be precipitated by hyperventilation, as his dad is going to help demonstrate here. Able to maintain tone, oftentimes they'll still have some degree of automatisms, last less than 15 seconds.
What have you do?
Make me do this.
Like this. Let me show you. Do it again. Can you do that, Tristan? Alright, so do that. Do this. Keep going. Keep going. Keep going. Keep going.
There it is. Started.
Keep going. Alright, so he's in an absent seizure now. Tristan, you there? 4, 8, what's 2? Time is it?
He's out of it.
Okay, so you heard something I said. Try it.
See there, he went into it, came out of it, less than 15 seconds. They also, here's another wonderful example that was posted on YouTube of a young girl who has absence events. They can look very subtle, and they often have facial movements. They'll reach up, they'll scratch their nose, they'll touch their face.
Haley, what's up? Haley, what's up? Haley, what are you doing?
Oh, thank you, William. That's good sharing. See, you got it? Yeah, they're sharing. It was 3 minutes. 3 minutes. I need bumps. Whoa, check out those bumps. Haley. 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 Hi. Can you hear me?
So you can see they're very subtle. They can be mistaken for just a kid who's not paying attention. They're in the differential of ADHD. That's what absence seizures look like.
All right, so moving on. So juvenile myoclonic epilepsy. So this is something that essentially it looks like an absence seizure, but it lasts longer, maybe up to 45 seconds, even a minute. This is going to be later onset, so like 10 to 12 years, even into adolescence. Mm-hmm. Or, as we mentioned before, it's going to be the absence seizure, or what you thought was absence seizures that keep going into adolescence. It's also characterized essentially by what we call myoclonic jerks that typically happen in first thing in the morning, sometimes right after the patient wakes up. And as that goes on, actually, as the disease process goes on, after they have these myoclonic jerks, they can actually have full-blown generalized tonic-clonic seizures first thing in the morning. And that's obviously quite different than absence, which really don't generalize to a GTC like this. The EEG is very similar, so it's 3 to 4 hertz generalized spike in wave, so it's almost the same. Treatment is valproate in this case, but that's the answer. So before it was ethosuximide, now just put valproate in your memory bank. And here again, prognosis will come up, and again it's quite good. So it's 80% of people or patients are going to have complete seizure control, but do remember this is a lifelong condition, so this doesn't go away like the majority of absence seizures. The patient's going to have this for life. So looking at continuing by etiology, the seizure types, so moving to structural. So structure abnormality in the brain equals a focus for seizures. So something that's different, that for whatever reason shouldn't be there, whether it's congenital, whether it's acquired due to some sort of trauma, infection, whatever. Brain doesn't like that. It's going to be sort of an irritative focus, and seizures can sort of emanate from that. As far as congenital causes, what we call focal cortical dysplasia or tuberous sclerosis are quite common.
And let's just talk about focal cortical dysplasias here a little bit. So all of your neurons start in the paraventricular region. This is in utero development, and they migrate radially, all hundreds of billions of them, before they ultimately end up in their final cortical placement. That can go awry, and sometimes they fail to get all of the way there. And you can see this on MRI, where there's just a chunk of gray matter where it shouldn't be, and because they haven't been wired properly, they'll start firing and discharging inappropriately, and can cause seizures.
All right. So when we think of them acquired, so this is any insult to the brain. So there's mesial temporal sclerosis. We'll talk a little bit more about that in a slide or two. Then there's stroke. So this is the big one. This is the most common cause of seizures in the elderly, especially in the United States. So a person has a stroke. There's an area of dead tissue. Brain doesn't like that. You can get seizures. Tumors can be especially irritative, brain tumors. And then any sort of major head or brain trauma, TBIs as we call them, can definitely produce seizures. And infections, a meningitis, encephalitis, something like HSV, herpes simplex virus, or when you look worldwide, neurocysticercosis is actually the most common cause of acquired epilepsy. Here is, just to show you, or to speak a little bit more about mesial temporal sclerosis. So this is the most common cause of temporal epilepsy.
Keep going there.
All right. So,
sorry about that. I'm just fixing this.
Not at all. So essentially you have scarring and atrophy of the hippocampus. And a scar in the brain doesn't like that. Okay? It is unfortunate that this can both be a result of or essentially the original cause of ongoing seizures. So you have a bunch of seizures, it can essentially destroy and scar up this area of the hippocampus, and that can cause more seizures. Other ways to get it are brain damage, like focal traumas, infections, and hypoxia. The hippocampus is just fairly exquisitely sensitive to this type of to these types of insults.
In terms of infection, main one there is herpes simplex virus. HSV notoriously targets the temporal lobes.
Presentation, or as far as what these patients will look like clinically, so not any different than what we already talked about with temporal lobe seizures. So focal onset, you can get some temporal lobe auras, automatisms, things like that. Looking at this picture, so we have essentially a blue arrow and a red arrow. The blue arrow is more or less normal. The red arrow, showing the left hippocampus, shows some scarring and then overall atrophy. So you can see how it's definitely smaller than the one on the right, and then just the coloring scheme I think is a little different than on the right side of the brain. Okay. How do we work up a seizure? So history is key. It's the first and foremost thing, because unfortunately a lot of times somebody comes in, there's sort of this vague description of shaking. Everybody assumes it's a seizure, but we don't necessarily know that, right? And so, finding anybody who was able to hopefully witness the seizure, or if it's repeated seizures, so friends, family, the person at the bus stop, if that's where it happened.
Yep.
And what you want to learn from them is, what did the seizure look like, or I should say the spell? What did the ictal period look like? What about before? What about after? And so you really have to have a good timeline in your mind of what this all looks like. The other thing is, we'll do basic labs, we'll check drug levels as necessary. Go back to the slide on sort of the provoking stressors, and those are the big things we look at. So we want to know their glucose. We want to know their sodium. We want to know what drugs they're on, right? These are the things that we can potentially intervene on that might have caused a seizure in the first place. This is just every time, this is part of the workup. And then let's say whether or not you know, or you have a good idea of what the etiology was or not. It's a first-time seizure. It could have been alcohol, it could have been low glucose, or it could be eventual development of an epilepsy syndrome. All these people get an MRI with and without contrast and an EEG. That is standard first-time seizure workup.
And when you have an MRI with contrast, that means with gadolinium enhancement, and the main thing you're looking for there is a breakdown in the blood-brain barrier.
Couple of just sort of principles of management. And sort of put it this way because I've always thought of anti-epileptics kind of like SSRIs, which is to say there's no wrong answer as long as you're dealing with or considering the side effect profile of the drug, the patient's comorbidities and the other medications that they may be on, or their ability to adhere to the treatment, because the drugs are quite varied in terms of how we give them, when we give them, so on and so forth. So principles are essentially as follows. You're using essentially whatever medication you choose to alter the neuronal membrane characteristics, right? So you want the neuron at the individual level and the neurons as a neuronal pool to be less likely to fire. Right? You don't want to reach threshold. You're essentially tampering everything down. You use the medications also to basically alter them, therefore the balance of excitation and inhibition on groups of neurons, right? So these are the neuronal pools. So individual neuron less likely to fire, groups of neurons less likely to fire, and then in certain cases, surgery. So sometimes we just plain cut out the part of the brain that is seizing because that's actually better.
People don't like there's a lot of people have a bias not to have parts of their brain taken out. Would you agree with that?
I would definitely agree.
And this
understood.
This includes in epileptics. However, as physicians, we can really help people cross that barrier because most people who ultimately go on to get epilepsy surgery should have had it done half a decade ago. Their outcomes would have been better. You are removing tissue that is causing problems that's actually increasing your tendency to have even more seizures. So the sooner you can take it out, the better. And just in general principles, to tie this together with other aspects of clinical neuroscience, well, we target medications mainly to minimize the side effects depending upon patient population. We do the same thing for antidepressant medications. We do the same thing for migraine prophylaxis. We're basically identifying the right side effects for the patient. With the exception there of what Dr. Asadi already talked about, with the occasions of if you have absence seizure, it's ethosuximide. If you have juvenile myoclonic epilepsy, it's valproate. But other than that, you can really pick which medication you want to use.
So a couple more things to just, as I say, sort of put in your memory bank and remember forever. So let's say a person comes in with a seizure, you do that workup with the MRI and EEG, you find nothing, that person is not put on anticonvulsive medications.
No medications for you.
Nope. Let's say you do that first time seizure workup and you find some sort of clear abnormality, some structural thing that's sitting there that shouldn't be there, something on the EEG that doesn't look right. Those patients do get placed on an anti-epileptic.
Boom.
All right. People, again, I think maybe this is the third or fourth time we say this, but it bears repeating. People who have repeated provoked seizures do not have epilepsy, and we do not place those patients on an anti-epileptic.
Yep.
Okay. And again, absence equals start ethosuximide, JME equals start valproate. All right. A couple other things. So I'm just highlighting here what I said before. We typically fit the treatment, the drug that we choose, to the patient's overall comorbidities, the side effect profile of the drug. So largely, you're going with their ability to take the drug and to not cause harm. So big ones that always come up, don't give valproate or phenytoin to a pregnant woman, right? They're very teratogenic, so it's bad form. Don't do it. Other ones come about, but beyond that, it's really you're seeking to minimize harm while also maximizing the chance that you'll minimize seizures. When it comes to surgery, so it's most effective for people with temporal lobe epilepsy. It is considered in other parts of the brain. We don't generally like going after seizure foci that if they're right next to, for example, where your speech is or your motor strip. But other than that, pretty much anything is fair game. The standard way of going about this is a patient is put on an antiepileptic. If they fail, you try a second. If they fail that, it's time for referral to surgery. We know now that adding on third, fourth, fifth drug, you're really not going to get anywhere if you weren't getting somewhere with the first one or two.
And you will see that. I mean, you will see patients who are on 4 or 5 anti-seizure medications. If you see that, go through the chart and find out why hasn't this person seen a neurosurgeon. There may be a good reason, but someone needs to ask the question.
All right. Now, essentially, having reached the point we are at, let's get into just a few sort of special topics that come up in seizures. And these are all, I think, definitely ones you're going to run into either in the hospital or in clinic during your rotation. The first is status epilepticus. This is a essentially seizure that goes on for longer than 5 minutes, or you have 2 seizures with no return to your baseline level of consciousness in between those 2 seizures. Now, this is the most recent definition. If you happen to be reading like an older book or older sort of review materials, you might see the definition as greater than 20 minutes or 30. This is out of date. It's anything longer than 5 minutes or 2 seizures with no return to baseline. Okay? This is actually a neurological emergency. There are not that many neurological emergencies, but this is one of them. It's up to 20% mortality. Okay? You essentially can end up with neuronal death due to excitotoxicity, so brain damage, right? So people that are seizing for days and we maybe miss it because they are in the ICU or intubated and it's not known, they don't have as good an outcome. They really don't. There are a couple of different types. The big one that you should be abundantly clear if it's in front of you is a generalized tonic-clonic convulsive status epilepticus. So this person just keeps shaking for greater than 5 minutes. So unlike the one we saw where it was all sort of tied off within about 2 minutes, here it just keeps going. There's non-convulsive status epilepticus or subclinical status epilepticus. Here you often have essentially no observable manifestations, or maybe something very subtle like just a little bit of eyelid flutter or something like that. You essentially need an EEG to diagnose. It is as we've learned in the last couple of years, a much more common problem than we realized in the ICU setting.
So the patient who's not waking up in the ICU, for example.
Exactly. Then 2 other types that we don't necessarily run into as much, but there's myoclonic status epilepticus. So these people keep having myoclonic jerking movements. It's very common after an oxic brain injury. And then there's refractory status epilepticus, which is terrible.
Yeah, it's status that doesn't respond to the medications we'll talk about right now.
All right. So you have a patient. You think they're in status. What do you do? So first thing, and always, no matter what, ABCs. Airway, breathing, circulation, you got to start there. Even if the patient is rocking and rolling in front of you. All right? Next up is essentially a benzo. Lorazepam is I think one of the more common ones we use. There's a couple others that are possible. You would administer that. You wait a few minutes, up to 5. Patient's still seizing. You give them a second dose of the benzo. You wait another few minutes. If the patient is still seizing, now you're going to give them a load of either Keppra,
which is levetiracetam.
Levetiracetam, thank you. Phenytoin or fosphenytoin. Really, if the patient's in the hospital, it's going to be fosphenytoin. It's just got a better side effect profile. Valproate, or I would say somewhat uncommonly lamotrigine, but that is part of the official protocol. If the patient is still seizing after that load, then you actually intubate that patient and you anesthetize them. So that's Versed, which is a benzo, propofol, which you're essentially inducing a coma, for lack of a better term. Okay. After all that happens, you image the patient, you hook them up to an EEG, and you start a very big workup looking for any kind of provoking factor.
Toxicities, infections, those sorts of things.
All right. Next up is febrile seizures. So this is a seizure in a young child during a high fever. Typically occurs in a young child about 3 months of age up to about 5 years. It's actually relatively common.
Yes.
It's 2 to 5% of all kids under the age of 5. So chances are you might actually know somebody who, when they were a child, had a febrile seizure. There's 2 types, simple and complex. The simple is a short duration. It's less than 15 minutes. Essentially, kids their brain is maybe a little bit more malleable than an adult.
Yep.
They're allowed to seize a little bit longer. You also wouldn't see any focal features if you're doing an examination. And if you have a simple febrile seizure, it's unlikely to progress to epilepsy, so we don't start anti-epileptics in those kids.
Reassurance and education for the parents.
Yes. Complex, a little different. So here it might last greater than 15 minutes. You might have focal features, and again, I sort of advise you to remember focal onset likely indicates a structural epileptogenic lesion, so you have to be worried about that. The other way to sort of categorize it as a complex febrile is multiple seizures in a 24-hour period. Here, 5 to 10% will actually progress to outright epilepsy. You'll do your MRI and EEG, just like any other first-time seizure, and if there's any abnormality there, you're going to start an anti-epileptic because these patients are likely to have epilepsy. Next up is what we call Todd's paralysis. This is essentially a phenomenon post-seizure 1. It's unilateral weakness after a seizure. And what makes it so sort of scary and sometimes aggravating is it looks exactly like a stroke.
Absolutely.
The differential would also include a complicated migraine, but the big thing that we always get consulted about and worry about is, did this patient have a stroke? Because just because you have seizures and maybe you have a history of Todd's paralysis does not mean you can't have a stroke.
And since this is usually hemiplegia, is it fair to say that these are usually due to a focal? They're after a focal seizure,
yes.
Right? So there was an abnormal discharge on one side of the brain. That once that is resolved, there's a postictal lack of activity from that region of the brain, and so then you end up with a patient very much like this who made this wonderful YouTube video. I'm going to go ahead and show you, showing what happens to them after they've had a focal seizure of the right hand. That is a fantastic video of what Todd's paralysis looks like.
All right. Next up, as far as special topics, is syncope. So this is any transient loss of consciousness due to essentially a global hypoperfusion of the brain. So, and this would be both cerebral hemispheres, right? You need to affect both of them to have a loss of consciousness. For syncope, there's a few differences between it and a sort of a true seizure. The sort of quote-unquote pre-ictal phase can look just a little bit different.
Mm-hmm.
You might have sort of a feeling of lightheadedness, nausea, maybe some sweating, overall pallor, some heart palpitations, or even sort of a graying or sort of progressive blackening tunnel vision.
These almost always happen while standing. They're orthostatic, right? I mean, it's almost always while standing, sometimes while sitting, essentially never while laying down.
So again, of the most common precipitants, standing too quickly is the big one. In some cases, for people who for whatever reason, can't regulate certain aspects of their autonomic system, prolonged standing can do it. And then there's what we call a vasovagal, so it's sort of like a fainting. There's, when you look at it, and it can be quite difficult, I think, in the acute phase, because again, this is, if a person just drops for any reason, everybody's going to be quite freaked out. But the sort of ictal part looks a little different. Eyes are going to be open, might deviate up and then maybe laterally, but you don't have the sort of true to the side deviation. And their body should be flaccid, so there shouldn't be a tensing like you might see in a generalized tonic-clonic.
Mm-hmm.
Again, it's usually quite brief, on the order of seconds, and they should recover rapidly. So it's quick onset, quick off set, as opposed to maybe a generalized tonic-clonic where it's quick onset, slow off.
I think most people, have seen people pass out before, but I want them to get an idea of the different motor manifestations that can happen during syncope. Because there's often, one of the things we want them to learn from the neurology clerkship is not all seizures shake, and not everything that shakes is a seizure. So this is a German video of a series of people. They precipitated orthostasis in syncope in a controlled setting, and just take a look at the variations here and the differences in terms of how these manifest in different people.
Only 10% of the subjects lay motionless during syncope. 90% had myoclonus. Myoclonus was usually arrhythmic and multifocal.
1, 2, 3, 4, 5, 6, 7, 8, 9.
Sometimes only a few mild twitches appeared. Occasionally, myoclonus was generalized and symmetric. Multifocal myoclonus could manifest itself with high-frequency bursts. %80 showed other non-myoclonic movements. This subject stretches his right arm and turns his head to the right.
So you get I hope everybody gets the idea that you can have syncope can manifest itself with quite a bit of convulsions, and you don't, unless they had a video on it, all you're doing is you're basing this off of the history, and a passerby may very well say this person fell down and had a seizure, when in fact it was actually a hypoperfusion event. Final special topic here is cataplexy, not catplexy. That was my fault. Don't blame Dr. Asadi for that. We'll get into more of this during the sleep talk, but this is a sudden intrusion of weakness. This is REM atonia that intrudes during wakefulness. It is triggered by an emotional stimuli such as laughter, due to a loss of the neurotransmitter orexin from the lateral hypothalamus and part of the narcolepsy larger syndrome. Here's one example of a young woman is having a fun time with her family, playing badminton, is laughing, and suddenly goes atonic.
Wake up, Sleepy!
So she's not asleep, by the way. They look
No,
like
I'm
they're
still
asleep.
filming.
The eyes will sometimes close, but if you ask her, and unfortunately they often get teased during these events. But it's sudden weakness. She is wide awake, but is just unable to move. And the motor activity itself will come back in pieces, in little bits. And then when it ultimately resolves, it resolves. Kind of. And there we go. All right, that is it. Next on Brain to Pods is going to be Volume 8, Demyelinating Disease. We're going to have a very special guest. I want to thank Dr. Asadi. What the people at home don't know is we filmed all of this about 3 hours ago, got about 90% of the way through, and then my computer crashed. We had to record this entire thing. So thank you so much for doing this twice. I greatly appreciate it. We'll look forward. We are going to hear from you again, neuropods, for neuromuscular disease, neuropathies, neuromuscular junctions, and myopathies.
Definitely. My pleasure. And well, yeah, we'll see everybody again.
Thank you, everybody.